For anybody who doesn't know me, I'm Paul Orchard. I'm one of the pediatric bone marrow transplant guys, and this is the Crivet Lectureship. And for some of you, especially the more junior people, might have not have known Bill Crivet. So Bill was here for about 50 years in terms of various levels of academia. He became department chairman at one point. He had very significant papers in oncology and hematology and coagulopathies and a number of disciplines throughout hematology, oncology. It's actually on the ground floor, too, of getting what's currently COG off the ground. So Bill was the driving force for a great many years in Minnesota. But one of the things he was primarily known for was the utilization of transplant for inherited metabolic diseases. And so we lost Bill about 10 years ago, I guess now. And every year we have a lecture to remember him and his contributions and to discuss the various aspects of metabolic storage diseases with kind of a bent towards transplant. So today I have the opportunity to introduce Dietrich Matern, who is here visiting us from Mayo. So Dietrich was born in Germany and went to medical school in Munich, right, and then did his pediatric training in Freiburg and came to the U.S. and did additional training at Duke and has been at the Mayo Clinic for about 15 years, I think now. Something like that? Yeah, some plus or minus a couple of years. And is now the director for the division of, help me out, what's your, laboratory genetics within the Department of Pathology there. So Dieter's nationally, internationally known in terms of newborn screening. And as some of these lysosomal and peroxisomal diseases are now going to be screened for, we thought it was a great opportunity to have Dieter come tell us what they're doing, where the field is going, and what the implications are going to be. So with that, Dr. Matern.
Thank you, Paul, for the kind introduction and for the invitation to come all the way from Rochester. I'm happy to talk about newborn screening at any time and about lysosomal storage disorders and X-Adrenoleukodystrophy because some of these conditions are now really a new standard of care in neonatal care. So I do have problems in. This looks like, there's a, okay, no, there. I have some disclosures. I work at the Mayo Clinic. They pay me every 2 weeks, and I appreciate it. And for some of the stuff I will talk to you about, have research funding from NIH, from the Newborn Screening Translational Research Network, and then some private foundations, the Legacy of Angels Foundation and the Hunter's Hope Foundation. And also relevant, maybe I'm a member of a Federal Advisory Committee on Heritable Disorders in Newborns and Children's that kind of discusses what kind of conditions every baby in the U.S. should be screened for, and also of the Minnesota Advisory Committee on newborn screening, basically. So this is kind of what I'd like to leave you today with, some basic understanding of what newborn screening was, is, and maybe in the future about the federal guidelines and how that works with states, and appreciate that newborn screening for lysosomal storage disorders or LSDs is not standardized between programs that screen for these conditions. So, but coming back to, I actually met Professor Crivet twice in my life, and I guess his too. First, as a second-year resident, sent off to Bristol in cold and wet December to go to this Cogent meeting where Dr. Crivet was apparently very involved with his colleague Dr. Hobbs in Britain. And I was sent there because I had an interest in bone aerosol metabolism. And along on the road, my boss in Freiburg sent our attending for pediatric hematology and oncology because they were in the plans of creating a bone marrow transplant unit at the Children's Hospital there. And so my boss heard about this meeting and said, hey, you guys, you go there and figure out what else we can transplant. And so I was just the fly on the wall, but I do remember Dr. Krivet, and apparently he was at that time talking already about Hurler disease or MPS I and transplantation, metachromatic leukodystrophy, and all these interesting things. I met him a second time, I think, for the first Krivet lecture here, because I came along with my friend and colleague Piero Rinaldo from the Mayo, who I think was the first speaker in this series. So I'll talk a little bit about the history of newborn screening, then the American College of Medical Genetics and Genomics uniform panel that then turned into the Recommended Uniform Screening Panel, or RUSP, and then about newborn screening for specific LSDs, Krabbe, Pompe, MPS I, and then also X-Adrenoleukodystrophy. So what is newborn screening? As pediatricians, I probably don't have to tell you that this is a public health program where the aim is to find babies that are at risk or will develop, if not treated, a serious condition for which there is treatment, and so you want to avoid mortality, morbidity, and disabilities. And classically, we've been doing this by collecting a blood spot on the second day of life on a piece of filter paper, and then it goes to the screening lab, and they look for biomarkers that are suggestive of the disease in the best case scenario. And over the last decade or so, a little bit of a change came along, which basically was screening for hearing loss and for critical congenital heart disease, which is done, of course, by audiometry or pulse oximetry at the bedside. It all goes back to Dr. Robert Guthrie. He was not a pediatrician. He was working in the field of oncology and had developed bacterial inhibition assays to measure basically drug levels in cancer patients to improve their treatment. But he also was the father of a son with mental retardation, and nobody knows ever why the son had this. But as an interested and concerned parent, of course, he wanted to learn more about it and joined patient advocacy groups and learned about all kinds of reasons for mental retardation, and eventually heard about the work of a person from Germany, Horst Bickel, who did a postdoc in the 1950s in England and was trying to figure out how to take out phenylalanine out of a formula and treat patients with phenylketonuria with that. At that time, the disease was known for more than about 20 years, and of course, all that we knew is it causes mental retardation and seizures and all kinds of things that are not good and is not treatable. And the idea was then, well, we know that phenylalanine is very elevated in these patients. Maybe if we find a way to reduce it, the patients will do better. And so he did this proof of principle and could show that it is better. But it only showed that it could improve patients with the diagnosis, but it could not cure them. And this is where Bob Guthrie then thought, well, why don't we try to change that? Another thing that happened that is very important is that Bob Guthrie got notification that a niece of his living in Minneapolis was diagnosed with PKU at about 1.5 years or so. So she developed symptoms and was diagnosed, and then she was treated with that new diet, but was never the same again, or never normal. So he thought, well, we should have picked her up earlier, and this is when he had the great idea to collect blood shortly after birth and then measure phenylalanine. And so he modified the bacterial inhibition assay to measure phenylalanine. Initially, he had done this to measure the concentration of phenylalanine in patients that are being treated, because it's an essential amino acid, so you cannot just remove it out of the diet. You have to give the patient enough to thrive, but not too much so that they don't develop symptoms. And so he collected, as you can see him here, initially basically in upstate New York, in a few hospitals, blood spots, and measured phenylalanine with the simple bacterial inhibition assay, which is basically an agar plate that has a bacillus on it. There's also an inhibitor of the growth of the bacillus, which is overcome by a large amount of phenylalanine. So you place a punch from the screening card, so a little blood spot, on the agar plate. And if you see something happening, as you see down here, then you know there's more phenylalanine than in everyone else. And that is an indicator that this patient may have PKU. So a very simple screening test. The patient advocacy groups were pretty strong, and as you will know, it hasn't really changed to date. They go to politicians to get what they want, which is fine. And they found a listening ear in John F. Kennedy at the time. And so there was a 20-state trial of the Guthrie test, and Massachusetts started in 1963, and from 1964 on, it basically extended to all 50 states and eventually included more conditions. A little an aberration happened a few years later when Massachusetts began screening also using urine as a sample, but they stopped this in 1991 because it was really a lot of effort and didn't really work that well. In Quebec, in Sherbrooke, they still offer this on urine, but don't have total capture of the population. And of course, at the same time, there's also the blood spot screening. An important historical event was when Charlie Rowe and Dave Milliken at Duke University, who had played around with tandem mass spectrometers as a very sophisticated and fast method to measure all kinds of things, including amino acids and acyl carnitines, thought, well, maybe we can do a better test for PKU and actually capture more conditions doing so. And so they hired Don Chase, and he was given the task to see whether tandem mass spectrometry would do a better job screening for PKU than the conventional bacterial inhibition assay. And he could show that this works actually quite nice and has a few advantages. And then in 1994, DNA analysis was first applied in newborn screening as a second-tier test in screening for cystic fibrosis, where you first do an IRT, immunoreactive trypsinogen, however, which is sensitive but not very specific. And so when you have a high IRT, screening labs now across the country look for at least 23 CF mutations before they report out the results. Ed Naylor formed a private screening company, Neogen, in Pittsburgh in the 90s and started first to use tandem mass spectrometry in his lab and really was a trailblazer in the screening arena doing so. And the first primary screening test for DNA was introduced in Wisconsin for severe combined immunodeficiency. And severe combined immunodeficiency is now part of the recommended uniform screening panel, as are some other conditions. We'll talk about it. So the traditional model of newborn screening was you have one disease you're interested in, so PKU, for example. You have one test, such as a bacterial inhibition assay. You have one marker, such as phenylalanine, and just a simple cutoff. So anything below something is normal and everything above is abnormal. And so that seems to be very simple, but it is not. It has never been. Because it is just a biomarker, it is not a diagnostic marker. So you will find patients with PKU, but you will also find patients that may be on TPN and have a high load of amino acids, or benign hyperphenylalanemia, or cofactor deficiencies that are difficult to treat and very devastating neurometabolic diseases in the tetrahydrobiopterin cofactor pathway. So Mcat deficiency, or medium-chain acyl-CoA dehydrogenase deficiency, is an important disease. Was first described in 1982. It affects about, and we know this from newborn screening, about 1 in 10,000 people. There's a known gene with a relatively common mutation, and the symptoms are those of a classic fatty acid oxidation disorder, where when you do not get enough calories in, so you're fasting or you're sick and you don't want to eat, or you have a fever and higher energy requirements, and your sugar eventually drops because you're running out of glycogen, and then you're trying to make energy from fat. It doesn't work. When you have a fatty acid oxidation disorder, you become hypoketotic and hypoglycemic. It's a Rye-like syndrome, and unfortunately, in 30 to 50% in the past, before newborn screening, these patients died with their first episode. So children are completely fine, look completely fine, and then they have an ear infection and don't want to eat, and the next morning they don't wake up. So it's a real issue. The nice thing is that you can easily treat it by avoidance of fasting or IV glucose if necessary, and then they will never have any symptoms or any problems. And the diagnosis is done by acyl-carnitine analysis by tandem mass spec. So tandem mass spec, again, you can use it for PKU, but apparently you can use it for MCAT, so you can do more than a single condition with a single test in less than 1.5 minutes instrument time. So very efficient, and if you have 2 of those, you can screen about 120,000 babies a year. So tandem mass spec is being applied now apparently for acyl-carnitine amino acid analysis to screen for more than 40 amino acid disorders, organic acidemias, and fatty acid oxidation disorders. But this technology can also be used for lysosomal storage disorders and for X-Adrenoleukodystrophy, and we'll, of course, talk about it. Here you can see a typical acyl-carnitine profile in a patient with Mcat deficiency, medium-chain acyl-CoA dehydrogenase deficiency. The asterisk are internal standards at a known concentration against which we can calculate the concentration of the patients. Here, medium-chain acyl-carnitine is a classical profile. And here's one, you have to trust me that this phenylalanine peak is higher than in a normal. So another application of tandem mass spec is as a second-tier test in newborn screening. And the idea here is to reduce false positive results because PKU or phenylalanine is a marker but is not specific. And there are more such markers which are problematic. And so if there may be sometimes a more specific marker that you can detect in blood spots, and tandem mass spec can help here, but it's not really an assay you can do on every baby. So you use the usual screen, and if you have an abnormal result, for example, for high methionine, you can do a second-tier test that looks specifically for total homocysteine, which is the condition that you actually try to identify. So you don't call out the first results to the physician who sent in the sample, and they don't have to get the family back in. You take the same sample you already have, you take another punch, you do the test, and that result overrules the primary screening result. So typically what happens, a baby is born, the sample is collected in the US usually on the 2nd day of life, sent to the newborn screening laboratory that does their testing, and if it's normal, everything is fine. If it is abnormal, then traditionally what newborn screening labs are doing, they're asking for a repeat blood spot. So you do the same thing over, you take another blood spot, and then if it is abnormal, then you finally get to confirmatory testing. What we don't like about this is basically the potential delay and also the extra cost of calling the baby back in, the anxiety you might be creating, and this I think is particularly important when we think about conditions such as lysosomal storage disorders. So again, with a second-tier test, you can avoid some anxiety, and it has been shown in this nice paper from our colleagues at Harvard more than 10 years ago that newborn screening is great as long as the results are reliable, but if you have false positives, it actually can create some anxiety and real distress for the families. So what we would then do with a second-tier test, when the first tier is abnormal, you take another punch again from the same screening card, and you do the second-tier test, which in most cases will be normal, and so you report out a normal result. And if the second-tier test is abnormal, then you go right to confirmatory testing. Now with tandem mass spec, there's also now a new kind of model in newborn screening, because now we can screening again for more than 40 conditions in a simple test, in one test, look at many markers, and theoretically have many cutoffs. So it makes it a little bit more complicated. So what about the American College of Medical Genetics and Genomics uniform panel that then turned into the recommended uniform screening panel? This was work HRSA contracted the American College of Medical Genetics to basically look at newborn screening in the country because of tandem mass spectrometry having really disrupted the landscape. There were states like Minnesota that in 2000 were screening for 5 conditions, Wisconsin was screening for 9, and Massachusetts was screening for more than 20. And so if you think of the US as a United States, it doesn't seem to be very united when it comes to newborn screening. So HRSA recognized that and said, okay, we have to really figure out what every baby in the US should be screened for. And so they asked the ACMG to address that problem. And again, my friend and colleague Pierre Rinaldo was one of the people deeply involved with this process, which, however, involved many people, including some here in the room, who helped with this. They looked at 83 different conditions that, starting from PKU all the way to some rarer birds, and tried to make sense, again, from expert input, because there's really not a lot of evidence for these rare conditions as to which ones should be screened for. And eventually they drew a line, and it was no accident that that line was drawn right after cystic fibrosis, because the Cystic Fibrosis Foundation is very powerful, and they wouldn't have it that CF wouldn't make the cut. So they made the cut right after it. So there are 29 primary targets that they felt every baby should be screened for, and then there are 25 secondary targets, and I will explain what those are. And then at the end, there are some that they deem just not yet appropriate, either because of the condition being just something we don't know much about, or because there's just no screening test. And among those, if you look more closely, is adenosine deaminase deficiency, one of the severe combined immunodeficiency syndromes, which is apparently now included. There's mucopolysaccharidosis type 1, Fabry disease, and X-ALD. They actually got the same score, and Pompe, and at the end, Krabbe disease. So some lysosomal storage disorders were already considered at the time, but were deemed not yet appropriate. They also came up with a scheme as to how you can actually add new conditions to the panel, how you could upgrade from a secondary target to a primary target, and maybe also how to remove something from the panel. If we really find out, well, it is not a disease that we're screening for, it's really just a biochemical variant, or there's no point in screening because we really don't change anything. And so, however, no one has yet brought anything forward to remove it. So there's some conditions that are being talked about, but nobody has done the work. So newborn screening, again, is a public health program, and in the U.S., while the Secretary of Health on the federal level can make recommendations, the Secretary is not ruling, and every state can do what the state wants to do for their own population. And this is a situation at this point, and you can see that basically the 29 conditions of that were the original primary targets are screened for in every state across the country. So that is a good thing. So that's the playing field is more even. And you can see again that there are some outliers. So Massachusetts, on their website, they say they screen for 64 conditions, Illinois 63, and we are in Minnesota, we're screening currently for 56. So what about lysosomal storage disorders and X-ALD? Let's talk a little bit why would you do screening for them. So as you all know, lysosomal storage disorders are historically devastating, but what is nice is there's more treatment. So Professor Krivet talked about bone marrow transplantation for a long time, and it really has been much improved, not the least by the work here at the U. So that is a real option. Then there's, of course, enzyme replacement therapy, chaperone therapy, substrate reduction, all kinds of things that you can do now for these patients. And what is also known and seems to be pretty logical, if you do the treatment earlier than later, it's better for the patient. So that suggests maybe you should do newborn screening and find them early. And there are now dried blood spot-based assays to screen for all of these conditions. There are several approaches for lysosomal storage disorders that have been published over the last 15 years. Nestor Camollis from Brazil started it off by developing a fluorometric assay using dried blood spots, but it's just looking at one enzyme activity in one test setup. It's easy to do, but the performance is also not so great, as I will show you. Then the idea is to also, again, do more with a single blood spot. The more conditions you want to do from a newborn screening card, you have to consider there's only so much blood on the card. So you want to do as much as, get as big a bang out of the blood spot as you can. So multiplex methods now exist to do multiple enzyme activities from a dried blood spot, and that was spearheaded by Ron Scott and Mike Gelb in Seattle. Using the same kind of approach, similar approach in using tandem spec as we use in the screening labs, and they modified it to use it, make it a little bit more complex using liquid chromatography, and then again, more recently, going back to the more simple approach. But we know a little bit now about how the performance is. John Hopwood in Australia thought, well, let's not do an enzyme assay, let's just measure the concentration of the actual enzyme protein in the blood spot, because we know they're milder variants, they're pseudodeficiencies, so they have the protein floating around, but it's so they're probably not sick, whereas the most severe forms usually don't have a lot of protein, so the idea was you'd get around the problem of pseudodeficiencies. And so he proposed an immunoassay, which is also multiplexed, is on a Luminex platform, and is easy to do, but very little is known about the performance. And when I talk about performance, it's about false positive rate, positive predictive value, false negative rate, and so on. And then finally, a company now called Babies Inc. Developed a digital microfluidics method using fluorometry, where they can measure 4 enzyme activities very simply from a blood spot. So which one should you use? So at Mayo, when all these things came up and people were really saying we should be screening for these conditions, we thought, well, what technology should you use? So we, with help from NIH and these foundations, said we want to do a study where we compare all of those platforms side by side and figure out how best to do the screening for these conditions. This is kind of what we had. We had a tandem mass spec for the flow injection MSMS analysis. In the middle are the liquid logic or advanced microfluidics instruments, of which we had 2. And then on the right side is, in the back, a Luminex instrument, and in the front, a puncher to punch the blood spots. So we wanted to do this with Minnesota samples, because at the time we were getting these samples every day, because we were collaborating with the state lab and doing part of the screen. But then we had all these privacy issues in the state, so we couldn't use the Minnesota babies, which delayed our study for a year. But luckily, California was willing to send us 100,000 samples over 2 years. So we did it with their samples. These are all the conditions that we tested for. 13 lysosomal storage disorders, all captured by the immunoassay, not all of them by tandem mass spec and by digital microfluidics. And then also, while we were at it, we thought, well, let's look at ceruloplasmin to screen for Wilson disease, and Friedreich ataxia using frataxin. And then also, since work came out of Dr. Raymond's former lab at Kennedy Krieger Institute, let's also look at X-Adrenoleukodystrophy. So this was a setup. This was all blinded samples, so we couldn't go back to the patient. So ultimately, if we had something abnormal, we had to do molecular testing to determine if it's true or false positive. Or unfortunately, often we ran into genotypes of uncertain significance. And the goal, again, was to figure out what is the best way to do the screening for these conditions. The goal was not to figure out what conditions to screen for. So that is not something we wanted to do at this point. Now, another way to get stuff done, again, is pressure from advocacy groups. And I mentioned that that's how newborn screening got started, and that's how it is continuing. The Advisory Committee on Heritable Disorders in Newborns and Children, again, took the ACMG report and adopted the panel, and the secretary created this advisory committee to look at future conditions and what should be added. So you can go onto the website and nominate a condition. Any one of you can do that if you feel like it. The way it works, after you fill out the nomination form, there is a nomination and prioritization work group which looks at the nomination and basically then takes it to the full advisory committee to make a decision whether it should be considered for screening or not. So it might get, after a vote, rejected, or it is going forward to an evidence review group. And they nowadays, with the latest law, have 9 months to do an evidence review to determine whether the test works, whether we know enough about the condition, what do we know about disease variants, how good is the treatment, is there treatment, what about the FDA, all kinds of things they have to look at. And then it comes back to the advisory committee, and then there's another vote whether the condition should be recommended for screening or not. So again, it could be declined, or it goes to the Secretary of Health to make a decision, and now she has currently she has 120 days to make a decision whether it should be added to the panel or not. So this is how it works. Very simple, and now again, could be very fast once you nominate a condition, if you get past a few of these hurdles. So this button has been used quite a few times since it became available in 2007, basically, first with SCIT. Just last week, we talked about guanidinoacetate methyltransferase deficiency, which was proposed, and that did not make it to the evidence review, but I expect that the proponents will come back in August, and then it will get to the evidence review, and that's a whole different story. But you also see that there are a number of conditions. SCIT was approved eventually in 2010, as well as critical congenital heart disease in 2011, and you see that several lysosomal storage disorders were proposed, but only Pompe disease last year, and then MPS I and now also XALD were added in February of this year, so just 3 months ago. What is Krabbe disease and why would anyone screen for it? The most prominent form is the infantile onset, because that really screams at you. A terrible condition. Initially, these babies seem completely fine until you really notice that they're more irritable than any other kid at that age, develop spasticity, developmental regression, and then hopefully get diagnosed. But there's really not much you can do at that point. But then there are also later onset variants, which have a milder phenotype, and some patients are not diagnosed until some psychiatrist, for whatever reason, maybe by accident, sends a sample to a laboratory and they find that the patient has Krabbe disease. So it's a very wide spectrum of phenotypes. What we know from the Hunter's Hope database, patient database, is that the onset kind of determines survival. And basically, again, if the patient is diagnosed early, means they have more significant symptoms and faster progression. What is also, and even more important for the proponents for newborn screening, is that in this work by Maria Escolar and Jordan Kurtzberg at Duke, they showed that patients that are diagnosed early and receive a transplant as the only real treatment option early in life, basically in the first 4 weeks of life, they have a much better outcome than patients diagnosed later. And here you see a comparison between the index patients in the family that became symptomatic, and you can see how quickly they die. They do basically what we know they would do, and the patients that receive the next sibling that is affected, being diagnosed basically prenatally or at birth and receiving a transplant very early in life, are doing much better. So again, that is maybe a good reason that you want to find them early and do newborn screening. So Hunter's Hope Foundation, we'll talk about them in a moment, in 2008 proposed newborn screening for Krabbe disease. The committee did do the evidence review, and after that came back, decided not to suggest this for further screening at this point. And basically the reason was that early infantile Krabbe disease, they felt, is not well enough described, and also we don't know enough about the variants. We don't know enough about how good the treatment really is and the outcome, even if you treat them early, and how good the screening test is. So lots of open questions, but that doesn't mean it cannot come back to the advisory committee and be reintroduced when the proponents do their homework and have answers to those open questions. But Hunter's Hope decided to go a different route. They decided, well, we can wait for some stupid federal committee to decide for us. We know that this is important. And Hunter's Hope, this is Hunter, and he is the son of James Kelly. Those of you who know football probably know him as a Buffalo Bill all-star football player. And he, unfortunately, had a son with Krabbe disease. And he, of course, was diagnosed late and also died, as you can see, more than 10 years ago. But he really felt strong that this is something that really shouldn't happen. And when he learned that there's a screening test, he lobbied very hard on the state level in New York to get newborn screening for Krabbe disease going, and he was successful with that, and as of 2006, they have been screening for Krabbe disease. So when the committee reviewed the proposal in 2008-9, they already knew about the experience from New York and felt it was just not there yet to do this in any other state. But if you scroll down on their website, you can find another button where you can take action for newborn screening. And this button has been used quite a bit. And I'm still asking them to change the photo down there because I think there's a better one. So that's all I know about football. So what is the situation in 2016 for lysosomal storage disorders and newborn screening? So New York is screening, as I said, for Krabbe disease, but they're also now screening for Pompe disease. Pennsylvania started this year to screen for Pompe disease. Kentucky is screening for, actually not, for MPS I, Pompe, and Krabbe disease. Illinois for 5 lysosomal storage disorders, and Missouri for 6. Except for Pennsylvania at this point, Krabbe is always part of it. And then you can see, again, through the advocacy efforts, there are other states where it has been introduced for screening and either passed or not, or they're still debating of what should happen. But some states in yellow already have a law, they just didn't start yet. What about Minnesota? So in Minnesota, early last year, Senator Miller from Winona, he got wind of an unfortunate child, Gavin Quimby, who was diagnosed with metachromatic leukodystrophy, so a condition that really hasn't been up for consideration for newborn screening. But they got involved or heard about Hunter's Hope and heard about it, and so they Gavin gave name to the SuperGAF Act that was it was introduced but didn't get all the way, because luckily MDH kind of intercepted and spoke to the senator and kind of said, we have an advisory committee, and why don't we take it there and have an adult discussion about what should be done. And so the advisory committee met last April in 2015 and took this on, and then there were some subgroup meetings to discuss the benefits or negatives of screening for 6 lysosomal storage disorders. And we came back in October. The committee voted to basically follow the recommended uniform screening panel, which at that time only included Pompe disease, but not everything. And I believe, and there are some people from MDH here that can maybe clarify it, I believe that Senator Miller was happy with that compromise. So what about Pompe disease? Pompe disease was brought twice to the committee, first in 2007, both times by Dr. Priya Krishnani at Duke. Initially there was an evidence review done, but it was rejected because while there was pilot study data available, those were pilot study from Taiwan. And as I can show you, that wasn't really a perfect scenario. And then they came back after they answered a few more questions, and then after there were more screening studies available done in the U.S., and it was approved, and then it took another almost 2 years until the Secretary included it in the RUSP, Pompe disease. So Pompe disease is acid alpha-glucosidase deficiency, or glycogen storage disease type 2. It also has a spectrum of phenotypes, with the most severe, the infantile variant, which based on Taiwan data is about 1 in 57,000 live births, and then the milder variants 1 in 20,000. And the reason I'm pointing that out is because once you start screening, those numbers change. Typically you find more of the milder variants. The diagnosis is classically based, of course, on the clinical presentation and history. These patients, especially in the infantile variant, often go first through a cardiomyopathy workup with elevation of CPK and other enzymes. And of course, confirmation is by specific enzyme assay of acid glucosidase and nowadays molecular genetic analysis. And newborn screening is done now for quite some time in Taiwan, and then more recently Missouri, New York, Illinois, and Kentucky. And then there were some other completed pilot studies or still underway, for example, in Washington at Mayo. And treatment is by enzyme replacement therapy. I'm not going to go into detail. Overall, enzyme replacement therapy is good, especially if you start it early. It is not a done deal. It requires some significant work, especially in the infantile form, where they often have cross-reacting materials to the enzyme when you start, so you have to do some immune modulation, which is, again, sometimes tricky, and we really don't have fully vetted treatment protocols for that at this point. So newborn screening for Pompe disease, and a few more words about performance. So let's look at a paper, I think the last one from Taiwan, about screening for Pompe disease and about some of their data. So they screened more than 400,000 babies in that time frame that they publish here. And the first screening result was abnormal in a large number of cases. And then they asked for a repeat, and that's how I mentioned earlier that people just repeat it again until it goes away or not. And so they even did a third repeat. And what they end up with is, if you look at the percentages here, is 1.4% on the first sample, and then it drops down nicely. They found 7 infantile onset Pompe cases, 20 late onset. So apparently the frequency is not, as they thought, more classic versus milder variants. They had a huge number of pseudodeficiency. These are patients that in vitro have low enzyme activity, but in real life have no problems. So we really don't want to pick them up by newborn screening. And so the false positive rate, in my opinion, is 1.04% based on the first screen. Because in my opinion, this is as soon as you have to ask the family to bring back a patient and have to tell them that something's potentially not right, just saying we're doing a repeat and maybe it goes away probably doesn't work for most cases, and especially for diseases like this where you have to talk about death and enzyme replacement therapy that will bankrupt you, those kind of things. I think we should start considering the false positives here. This is based on data that the Minnesota Department of Health provided last month at the advisory committee meeting. In 2015, nearly 70,000 babies were screened in Minnesota, and you can see what the false positive rates are for the various groupings of conditions. But what you really have to consider is not a single group. So CAH, 0.14%. That sounds pretty good. But in the end, it's the total false positive rate that a practitioner will have to consider, because these patients will come to anyone who takes care of these babies and not just to specific groups. If we had 100,000 babies in the state, there would be 195 unnecessary evaluations or repeats every month. And if you consider time, effort, cost, anxiety for families, I think that's an important number to keep in mind. So what could you expect if you screen for Pompe disease? So this is from a review that we published last year about available data from various countries based on technology. So in Taiwan, initially they used fluorometry, and then they moved to tandem mass spec. Austria, Hungary, and Washington all use tandem mass spec in their pilot studies, and Missouri uses digital microfluidics. And you can see that the false positive rate really doesn't stick with a specific platform. So it must be cutoffs and other things. Why would you have a tandem mass spec in Taiwan 1.8% false positive, and in Austria only 0.003? So there's some other issues at hand. Now, more importantly, the frequency overall for Pompe disease, including late and early regular classic onset, is much higher than we ever expected. In Missouri, 1 in 5,400 babies. So what would come close to Minnesota? Maybe Washington, 1 in 27, or something in between. So it is not such a rare disease, at least from a geneticist perspective. So again, in May 2013, the advisory committee decided, yep, we think that should be screened for, and forwarded to the secretary, and she responded then almost 2 years later and said, yep, we'll add Pompe to the RUSP. Also, the Affordable Care Act requires that health plans must cover conditions included in the RUSP. Unfortunately, that doesn't mean the treatment, it just means the screening, which is very sad because the treatment is very expensive. And this is a recommendation, and the states, of course, don't have to follow it. But she also encouraged that federal agencies support states in bringing this up in their programs. A few words about MPS 1 was proposed in 2012 and added again just about 3 months ago. It's alpha-L-iduronidase deficiency, an autosomal recessive condition, just like Pompe disease. And it also has a spectrum of phenotypes. The most severe, Hurler disease, and then the milder variants, Hurler, Shire, and Shire. And nowadays we call them MPS 1 and MPS 1 attenuated because I guess it's easier, also easier to pronounce. And the diagnosis is established basically by measuring glycosaminoglycans in urine traditionally, but we can do this also now in blood spots. And enzyme assay in all kinds of sample types, blood spots, leukocytes, or fibroblasts. And molecular genetic analysis is also available, but the problem with this and many other conditions is that there are a lot of private mutations which in real life translate to so-called variants of uncertain significance, which you can deal with relatively easily when you have a patient that has the clinical phenotype of the disease that you wonder about versus having a healthy baby in front of you that has now 1 or 2 mutations that are variants of uncertain significance. What does that mean in terms of treatment? And treatment for MPS 1, of course, you know best, is by enzyme replacement therapy and transplantation, and now also some additional options to improve outcomes. This is from a review a few years ago that just kind of talks about the various phenotypes and symptoms observed in Hurler, Shire, and Hurler, Shire. And I just want to point out that for the mildest variant, hernias, some regular things that you might see or an internist might see in a patient who seems to be otherwise fine may actually be MPS 1. And the reason I'm saying that is because in our study we found genotypes of uncertain significance and low IDUA activity in 1 in 5,000 babies. So are these just pseudodeficiency? Probably many of those, but I wonder how many patients go to a hand surgeon and get carpal tunnel surgery, but they're not typing all day or pipetting. Maybe they actually have something else, such as a mucopolysaccharidosis that is very mild. The prevalence, again, the idea from the review is that most of the patients have Hurler disease, about 60%, and only 13% have the mild variant. And also in the standard literature, you find that the idea is that the classic MPS 1 is more frequent than the mild. And again, looking at real data, that probably is not true because, again, in Missouri, 1 in 15,000 have low IDUA activity and a genotype that they believe is MPS 1 and have elevated urine glycosaminoglycans. So they have MPS 1, but probably not the classic form. So a little bit more on performance. If in Minnesota we added now lysosomal storage disorders, and if we go based on published information, if we did what Austria did in their short pilot, and we had that kind of false positive rate, we would only add 6 more necessary evaluations every month if we had 100,000 births. If we did what Taiwan did just for Pompe, we would have 87 more. So I don't know if we want to have these discussions more than once so often in a month. So we have to be consider the false positive rates. X-Adrenoleukodystrophy, Dr. Peters, who I think was at the U at some point, was the advocate along with some other groups to screen for XLD, and he came twice, and again, it's now part of the RUSP. I'm just going to glance over, given the time, about what XALD is, because I'm sure you hear this more frequently from Dr. Raymond. Important is the prevalence. Also important, although it's X-linked, 65% of carrier females will develop disease, but not necessarily while U.S. pediatricians see them. And it's the most common peroxisomal disorder. We understand this disease fairly well. There again are variable phenotypes, Interestingly, these variants can occur in the same family, so it's family history alone is not going to help you in determining the outcome for the patient. And again, the most severe is the cerebral form, which is not detected clinically at birth, but again, because of potential treatment improvements, you consider this for newborn screening. Adrenomyeloneuropathy is a milder, later onset variant, and so treatment options are, of course, hormone replacement, Lorenzo's oil to some degree, and then transplantation. And again, this group here published a very nice review article in 2011 about the outcome of transplantation, and could show that patients basically identified early, with a low score and a good neurologic function score, when you treat them early, they do better long term. So that again is another basis to consider newborn screening for this condition. Now, is there a test for that as well? And there is, and the marker here is lysophosphatidylcholine, which is a sensitive marker but not specific, and that's potentially okay. Again, Dr. Raymond was deeply involved before he joined the U in bringing up a screening test. They got a tiny little bit of help from us through Dr. Tortorelli. She was not so happy about doing this by liquid chromatography, so we figured, well, can we do it differently? And so we use it, we do more the typical approach. And then yesterday we got accepted a paper that describes how you screen for 6 lysosomal storage disorders and the lysophosphatidylcholines in the same assay, which actually is already being used in New York for more than a year. So this is a situation. New York and Connecticut are currently screening for XALD, and other states, again, Minnesota would fall into the ones that would do it since it's now part of the RUSP. Dr. Raymond was also involved very involved with the New York screening program, and they already published guidelines as to figure out what an abnormal newborn screening result means, and I'm not going to go in detail. I just want to point out again the concept, and I guess I will start to point out the concept of a primary condition versus a secondary one. The core or primary condition is, of course, X-Adrenoleukodystrophy. But because lysophosphatidylcholines are not a specific marker for XALD, but actually also elevated in other peroxisomal genetic conditions, all of these other conditions become secondary targets. So this is the overall recommended uniform screening panel as of today. Basically, it includes Pompe disease, and then the recent newcomers. What they don't list, again, on the secondary condition side are all the other peroxisomal disorders that really belong here now. So 34 conditions with detected via various means. And so back to this map and talking a little bit about Kentucky. Well, first about the state. At the advisory committee meeting last month, we were told that MDH plans on starting as early as January. So basically for Pompe, MPS I, and X-Adrenoleukodystrophy. We actually have been asked, after Kentucky passed a law to screen every baby for Krabbe disease, they asked us if we could help them, and we said no, unless we can screen also for MPS I and XALD and Pompe disease, because we figured those will be conditions that end up on the RUSP real soon. They said okay, but not XALD because it's not an LSD. So fine. So as of for the last 3 months, we've been receiving blood spots from Kentucky. Why don't we want to do screening for Krabbe disease? Several reasons. Krabbe disease, the approach they use in New York, they do an activity measurement, and if the activity is low, then they do sequencing, which is difficult for most screening labs to do. It is also expensive because you cannot batch it. If you have to treat the patient with a bone marrow transplant within 30 days of life, you cannot wait a week to do the molecular. You have to do it right away. So basically you have one sample once a week that you have to do this for, which is for most labs, including mine, something we would not do based on efficiency. So they screened more than 2 million babies. They used initially MSMS just for one condition, which is expensive. They did the stat DNA testing and follow-up. They did the sequencing 620 times. They found 5 early infantile Krabbe cases, of which 4 were transplanted, 1 declined and died. Of the transplanted, only 2 survived. And then they have a good number of cases that are hanging out there, and you don't know whether they will develop any symptoms. So newborn screening for Krabbe disease, there's currently no simple approach. So what should you do? The options are don't do it in the first place. Maybe only define what you actually want to screen for. So I only want to identify cases with a 30 kb deletion, which is indicating if it's homozygous, the patient has a severe form. Or you can do maybe looking for something else, and we'll talk about cycosine as a specific marker for Krabbe disease. So cycosine is a substrate for the enzymes that's deficient, galactocerebrosidase. So it accumulates in patients with Krabbe disease, which is not unusual. It's similar to PKU, where we look at the precursor of the substrate for phenylalanine hydroxylase. So we try to determine whether it could be helpful. And what we found, these are healthy newborns, and these are the cycosine levels. These are samples from controls that are not newborns. So this is basically the normal range. These are carriers of a mutation for Krabbe disease, and you can see that there seems to be an outlier here, so I wonder what's going on. This is carriers identified through newborn screening, and looking back at the original newborn screening card. These are patients that were deemed pseudodeficient, so you can see they basically have normal values. This is a group of patients where we obtained the original newborn screening card from asymptomatic patients with late onset Krabbe disease. So they will develop symptoms. You can see some have normal, some have elevated concentration of cycosine. These are patients who were symptomatic for more than 5 years, and these are newborn screening samples from early infantile Krabbe disease cases. And you can see that they have elevated cycosine basically at birth, as do patients that were just diagnosed. So it seems like it's elevated in early infantile Krabbe disease. It is inconsistently elevated at birth in late onset cases. It seems to be elevated in all symptomatic cases, but what happens, when does it actually go up? I mean, if it's not elevated at birth in late onset cases, could this be a marker where you can follow it as a simple way to figure out when you have to do a bone marrow transplant? We know a little bit about the mouse, the Twitcher mouse, which is a Krabbe animal model, and their cycosine levels accumulate over their lifespan, which is about 40 days. So maybe it is a progressive marker. So we are using this as a second-tier test now in newborn screening as we do this for Kentucky. So we measure the activity of galactocerebrosidase. If it is low, then we measure cycosine, but we also do overnight the 30 kb deletion. If cycosine is elevated, we know the patient has the disease. If the 30 kb deletion is homozygous, we know the patient has the disease. If those are inconclusive, we do sequencing, but we think now we don't have to do it in a stat mode. We can take the usual time that it takes us to do these kind of things to be efficient. And then you get your answers. So there are lots of open questions about cycosine. I'm not going to go through all of those, but I do want to mention this paper that just came out a few days ago, which talks about the clinical outcomes of children with abnormal newborn screening result. And really important, I think, are the conclusions, which you can read. And basically, New York's experience raises questions about the risks, benefits, and practically of screening newborns for Krabbe disease. It is imperative that objective assessments be made on an ongoing basis as additional states begin screening for this disorder. So I think after basically screening for 10 years to have this conclusion, I think in Minnesota we did the right decision not to screen for Krabbe disease at this point. So what else could help? Piero at Mayo 10 years ago started trying to help screening labs to do a better job in newborn screening. Lots of people were involved in the early papers and still involved. You can see that there's a worldwide collaborative effort. And he showed a few years ago that if California was using these tools and second-tier tests as they could, they would reduce their false positives by 90%. That's a state with 500,000 births a year. So a lot of healthcare costs could be saved by doing this. This is our approach now again for Kentucky. We have, looking at several enzymes and use clear, we have second-tier tests for MPS1 glycosaminoglycans, and I mentioned those for Krabbe disease. We're working on one for Pompe disease, and so far screened about 15,000 Kentuckians. Had one true positive in the second week for MPS1. That patient, Paul told me, is probably being treated now in Cincinnati. We had one false positive because we didn't trust our second-tier test at that point. Meanwhile, we think we have it validated and we're comfortable that even patients with a later onset MPS1 variants should have elevated glycosaminoglycans at birth in the blood spots. So overall, this is our current positive predictive value, and of course, these data are very preliminary with just 15,000 babies screened. So in conclusion, there's a new standard of care in newborn screening, which now includes Pompe, MPS1, and XALD. The assays, I think, are all sensitive, but not sufficiently specific, so you need, I think, second-tier tests to improve that. I think molecular testing as part of newborn screening has limited value. In New York, they do it even for XALD and Pompe, but really because they say it's so difficult to get reimbursement for the physicians when they do it afterwards, so we do it for you. Now, not every state is as rich as New York that they can just do this kind of stuff. And if you get variants of uncertain significance, I don't know how much it helps you. Follow-up guidelines are available for XALD thanks to the work of Dr. Raymond and others, but I think they're still lagging behind a little bit for Pompe and for MPS1. Also of importance, no other lysosomal storage disorder has been proposed recently for inclusion in RUSP. So those Fabry disease, Niemann-Pick, Krabbe, they were all declined and no one has come back yet. So we'll see what happens in the future. And with that, I thank you for your extended patience and just want to acknowledge everyone, my lab at the Mayo and my colleagues there, and then all those who gave us support in blood spots or money, etc. Thank you.
So probably have time for a question or two, so any questions? I was kind of interested for some of the states that make their screening contingent on the RUSP, but they don't necessarily allocate funding to do that. What's the mean time to get something off the ground then once they get the go-ahead from the RUSP? Yeah, so it really has nothing to do with the RUSP. Even the states that go the legislative route and add, for example, in Kentucky, Krabbe disease, it never goes along with funding. They say we're going to screen for this, and then the Department of Health says, okay, we need space, we need equipment, we need people, and then they say no. So in Kentucky, if you follow the press there, the state said we need $1 million the first year, and then $250,000 every following year. And someone there said, no, that's too expensive. There must be other labs that can do it for $250. The reagents alone are $1 per baby. So it's not possible to do it at that price. Yep.
Dr. Matern, is Mayo going to be running, or I'm assuming you're already trying to bring it online or whatever, are you guys going to be running these new tests?
I don't think so.
So do you know who it is?
Minnesota Department of Health is going to run it.
Okay.
Yeah.
All right.
So in most states, is it paid for by the state, or, I mean, in some circumstances, it get paid for by insurance, isn't that?
Yeah, so that is also variable. So in New York, it is paid for by the state, as far as I know. In Minnesota, you pay for the screening card. Every hospital has to buy the screening, or now you get a bill every month or so about the screening cards they received and where they provided the final result. So the repeat, they don't charge for that second card. In other states, it's all over this. And in the hospital, so at Mayo, it is basically then charged to the insurance as part of the delivery cost or whatever's. is.
Any questions? Thanks very much.
You're welcome.
Appreciate your being here with us.